We're sprinting through everything you need to know from that very first incision all the way to final suture removal, without missing a single beat.
All right, let's jump right into Section 1, Surgical Drains Explained. We're going to look at how we manage the fluids left behind after surgery.
So look at the evolution of fluid management we've got here. Old school open drains, like those corrugated rubber ones, they literally just leave a mess. Pus and fluid just trickle out and soak the dressing. But modern surgery, it relies heavily on closed negative pressure systems. These actively suck out fluids using a vacuum. You'll frequently see the Romovac, which has this circular tubing, commonly used after breast or neck surgeries. And for abdominal surgeries, the Jackson Pratt is incredibly common. It uses a really distinct flat tubing with multiple openings to efficiently drain those fluid collections.
Now, the absolutely crucial point here is knowing exactly when to pull these drains out. Seriously, listen up, because removing a drain too early is a classic mistake. For instance, after breast surgery, you must wait until the Romovac output is strictly under 40 cc's per day for 2 consecutive days. If you pull it prematurely, you are basically inviting a seroma, which is a really stubborn, annoying fluid accumulation. Oh, and if you're dealing with a chest tube and an underwater seal bag for a pneumothorax, always ensure the tube's lower end remains safely submerged in water. It's a one-way street, right? It lets air out, but acts as a seal, so air literally cannot be sucked back into the thoracic cavity.
Moving right along to Section 2, Essential Surgical Knots. This is the literal foundation of surgical security. Okay, there is a vital difference here between success and catastrophic failure on the ward. A square knot, also known as a reef knot, is secure precisely because you cross the threads on every single throw. On the flip side, you should never, ever use a granny's knot. This happens when you fail to cross your threads, and it essentially acts like a slip knot. Think of it like a poorly knit sweater from your grandmother. If one thread goes, the whole line easily unzips. In fact, if you use a granny's knot to tie your scrub pajamas in the theater, you might just suffer an embarrassing wardrobe malfunction when they slip right off. So always cross your threads to lock in that secure square knot. Now, if you want to master the highly secure surgeon's knot, just follow these steps. It's super simple. Wrap the thread 2 times around your needle holder, cross it to secure that double throw, and then follow up with a single wrap and cross it again. Honestly, knowingly or unknowingly, if you have ever sutured before in your rotations, this exact 2-then-1 motion is exactly what you were doing. Okay, so now that we can tie a secure knot, let's dive into Section 3, Mastering Suturing Techniques. We're going to look at how we actually close the wound.
The golden rule of skin suturing is actually really simple. Skin needs its edges to be everted, meaning turned outward, for it to heal properly. You achieve this perfect aversion by making absolutely sure your needle enters the skin strictly at a 90-degree angle. Furthermore, you really need to memorize the 2x rule. It goes like this. If your bite depth is x, the distance between your 2 consecutive sutures must be exactly twice that, or 2x.
All right, let's test your knowledge with a high-yield question that frequently pops up in surgical exams and, honestly, real-world emergencies. When simple sutures just aren't giving you that needed aversion, you step up to mattress sutures. But here's the question. Between vertical and horizontal mattress sutures, which one has the absolute least cut-through rate on fragile skin? Think about it for a second.
Got your guess? The answer is the horizontal mattress suture. If you look at how it works, the bites are taken side by side at the exact same depth. Because the thread runs horizontally parallel to the wound, it safely distributes the tension over a much wider area. This gives it the least cut-through rate, which makes it an absolutely excellent choice for delicate or highly tense skin.
As you level up, your toolkit naturally expands. For a cosmetically invisible scar, you're going to use a subcuticular stitch. You take bites entirely from the inside using an absorbable 3/0 monocryl thread, meaning no track marks are left on the skin. Pretty neat, right? Now, when you're finishing a long continuous suture, you'll lock it down with an Aberdeen or cobbler's knot. Dealing with a massive dead space? The far, near, near, far technique obliterates large cavities perfectly. And for explosive emergencies, like compartment syndrome where the muscle is bulging out of a fasciotomy, we use the shoestring method to gradually pull the wound closed over several days. The big takeaway here? Choosing the exact right technique for the exact right tissue really matters.
Let's move on to Section 4, Needles and Suture Materials. We're diving into the actual hardware, the needles and threads you'll be holding. Quick pro tip. Always remember to grab that needle exactly at the 1/3, 2/3 junction. That's 1/3 from the swaged end where the thread attaches and 2/3 from the sharp point.
Please, I am begging you, whatever you do, Don't be the intern who desperately pushes, bends, and ultimately snaps a delicate round body needle because they were trying to get it through tough skin. It is such a classic mistake. Instead, just use this simple mnemonic. Round body needles gently split tissue and are for delicate B structures, like bowel, blood vessels, bladder, and the bile duct. On the other hand, cutting needles have a really sharp triangular cross-section meant to literally slice through tough S structures, namely skin and sheath. Just remember, match the needle to the tissue. Now, this table is your ultimate rapid-fire cheat sheet for suture materials. Notice the critical difference here. Natural materials like catgut, which, by the way, actually comes from sheep's submucosa, not cats, and silk trigger a really high inflammatory response in the body because of their natural antigens. On the flip side, synthetic materials are chemically engineered to be completely inert. So a synthetic, non-absorbable material like Prolin is the most inert suture you can possibly use. It's perfect for permanent structural fixes like hernia meshes or vascular repairs. You also need to understand the vital mechanical trade-off between single and multi-strand threads. A braided silk or vicryl thread is honestly an absolute joy to handle. It knots securely with just 3 throws. But there's a catch. Its microscopic intertwined crevices can act as a safe harbor for bacterial infections. Then you have monofilaments, like Prolene, which is just a single, smooth strand. It actively resists bacteria, but it has intense memory, meaning it stubbornly fights to retain its coiled shape. You'll literally need 6 or 7 knots just to force a monofilament to stay put. Okay, the absolute crucial point when closing an abdomen is managing tension. Over-enthusiastic interns often take short, tight, continuous bites to impress their attendings. But if you pull a thick Proline thread too tightly, it creates massive tension that violently cuts right through the tough rectus sheath. This can lead to a catastrophic burst abdomen. No one wants that. So always follow the Jenkins theory. Use a continuous thread that is at least 4 times the total length of the wound to properly distribute that tension. Imagine you just finished repairing a blood vessel with your Proline suture. You've got clamps on both sides and air trapped right in the middle. Here's what you do. Always remove the distal clamp first. Why? This allows retrograde blood flow to safely flush those dangerous air bubbles right out of the line. Only after the air is completely purged do you release the proximal clamp to check if your repair is perfectly watertight. Let's transition over to the removal phase because honestly, timing is everything. If you leave a stitch in too long, you're going to create permanent, ugly train track scars. That's exactly why highly visible facial sutures must be pulled as early as day 3. Conversely, high-tension, highly mobile areas like the abdomen need maximum structural support. Those stitches absolutely must stay in for a full 12 to 14 days to prevent the wound from reopening. Quick definition check here because exams absolutely love to trick you on this. Do not confuse memory with elasticity. Memory is simply the suture's stubbornness. It's the exact reason why a Proline suture instantly coils right back up into a tight loop the very second you pull it out of the packet without you even stretching or pulling it.
All right, we made it to Section 5, Bowel Anastomosis Basics. This is our final module where we're basically connecting the plumbing back together. Now, remember how we said skin needs to be everted? Well, when repairing the bowel, inversion is the absolute name of the game. The edges must turn inward to prevent leaks. Also, burn this into your brain. The submucosa is the strongest anatomical layer of the bowel wall. It is your anchor. If you're doing a classic 2-layer cocker stitch, your first Albert layer uses vicryl through all layers, and your second Lambert layer uses silk specifically to force that inversion. And hey, if you opt for modern linear or circular staplers to save time, be hypervigilant. Bleeding from the staple line is actually the single most common complication. Let's pose a scenario. You're connecting a tiny ileum to a massive colon after a hemicolectomy. How on earth do you bridge that gap? Well, you use what's called a cheetah's split. This is a longitudinal slice made on the safe antimesenteric border, which is away from the blood vessels, of the narrow bowel to widen its mouth, completely fixing the luminal disparity. Once you're connected, you finish the corners with a Connell's loop. The edges are the most common places for a catastrophic leak, and this specific suturing loop guarantees total watertight mucosal inversion. We have covered a massive amount of ground today at an absolute sprint.